Okay, so we're going to move to the next talk, which is going to be about cerebral aneurysms. So again, my disclosures, they haven't changed since the last talk. So just a little bit about why we care about aneurysms. I think most everybody in the audience is familiar with brain aneurysms, but here are just a few of the statistics. About 1 in 50 people in the United States has a brain aneurysm. A brain aneurysm ruptures every 18 minutes or so. So in the past talk, during thrombectomy, when we talked about thrombectomy, somebody had a ruptured brain aneurysm. In the next 20 minutes, as we talk about aneurysms, somebody's going to have a ruptured brain aneurysm. Hopefully it's not Marvin. He raised his hand there. The true number of ruptured brain aneurysms in the United States is probably underestimated because about 10 to 15% or so of these patients will die before they reach the hospital. Of the patients that make it to the hospital, the mortality rate is up to 40% or so. And of the patients that survive, about half of them have a permanent neurological injury. So this is really the impetus for why we treat and care about aneurysms. As far as assessing aneurysm rupture risk, this is something that's a question that we all have. We try and incorporate it into our practice. The patients always wonder about what their true rupture risk is. And the bottom line is it's a very hard thing to assess. The most commonly used system to try to describe rupture risk is something called the phases score. It's based on the background of the patient, whether the patient has hypertension, what their age is, the size of the aneurysm, have they had an earlier subarachnoid hemorrhage, and the site of the aneurysm. And you would come up with a 5-year cumulative rupture risk based on this scoring system. But if we kind of dive into the studies that were used to develop this scoring system, there are some flaws in that. And based on a phases scoring system, these two aneurysms shown here are essentially equal. These are both anterior communicating artery aneurysms. One of them is a little less than 2 millimeters. One of them is a little less than 7 millimeters. And these aneurysms would have identical phases scores. However, one of these aneurysms is a ruptured aneurysm, and that's how it was discovered. This is a patient who came in with a large subarachnoid hemorrhage secondary to the ruptured ACOM aneurysm, which had to be treated. And now you can see which aneurysm it is based on what the coil mass looks like. And a low rupture risk in a phases scoring system does not equal no rupture risk. So for example, a 3 millimeter aneurysm, phases score of 3, which equals a 5-year rupture risk of 0.7%. I think most people would agree that's a very low number. However, this patient did show up with a subarachnoid hemorrhage. This is what the CT scan looks like. That's what the brain looks like from such a hemorrhage, and this patient wound up dying. So just because you have a low phases score and you have a low risk does not mean that risk is 0. And phases would treat pretty much all of these aneurysms equally. On the left, you see a very small aneurysm, 1.5 millimeters, but it looks like the aneurysm is cherry red in appearance and probably has a very weak wall. In the middle, you see a 4 millimeter MCA bifurcation aneurysm, which I would argue looks very normal, other than the fact that it's dilated. It looks like the parent vessel it came off of. And then right next to it, you see an approximately 7 millimeter MCA aneurysm that the bulk of the aneurysm kind of looks normal, except for a very small bleb. So aneurysms have the wall thickness and the shape of them can have a lot of variability, and all of these aneurysms on the screen essentially have very similar phases scores. So we really need a better way of assessing aneurysms other than just size alone and the patient's history. The phases score, as kind of we've been talking about, is not perfect and doesn't take into account a lot of things we know contribute to aneurysm risk, such as female sex, female sex, history of cigarette smoking, family history of subarachnoid hemorrhage, the shape or morphology of the aneurysm, whether the patient has multiple aneurysms or other genetic conditions. These are the prospective studies that were used to design the phases score. The slide is not designed for you to actually read this, but you can see 2 of the studies which contributed the largest percentage to developing the phases score. In each of these studies, about 50% of the patients that were enrolled in these studies were actually taken out and treated during that time. So it's clear that there's a population of aneurysms that people think are dangerous, and these did not go into assessing the phases scoring system. And phases should just be used as one tool in your toolbox when you're trying to counsel your patients. As far as imaging goes, aneurysms are typically picked up using CTA or MRA. Cerebral angiography or digital subtraction angiography is another imaging modality, which is pretty much the gold standard. This is the different resolution that we get from these images. Excuse me. CTA and MRA are pretty much equivalent as far as their resolution. DSA, even though it's an invasive study, gets you much better resolution. When you're trying to order an MRA for your patient, you do not want what I call low T. Okay, this is a young patient who was found to have this PCA aneurysm that was followed for a number of years with 1.5 Tesla MRA. This I would say is the radiographic equivalent of this medical condition, low T. All right, so it doesn't provide you all the information that you need. This patient ultimately had a higher resolution 3 Tesla MRI, which showed it actually was not an aneurysm, it was just a vessel loop, and we could clear that patient and go on to lead a normal life and not have to worry about a future with an aneurysm. Catheter cerebral angiography, as I mentioned, is still the gold standard for evaluating blood vessels of the brain, including aneurysms. This gives us much more detailed pictures about what aneurysms look like, what the shape looks like, do they have morphological irregularity, what are the branches associated with them. And here you can see the comparison in a patient. This is what a patient's MRA looked like, showing a basilar apex aneurysm. And you can see the significant amount of improvement in image quality found with digital subtraction angiography. This patient just so happened, this is a procedure done at a top 3 neurosurgery program in the country, where they went in with the intention of treating this aneurysm. You can see a catheter in the upper basilar artery and a contrast dye injection, and it was found that this aneurysm had potentially some perforating arteries coming out of the aneurysm dome, and the procedure was aborted. There are variations in catheter angiography and the variations of the information you can get from them. Not all angiograms are performed the same. This patient came to UCLA. This is what I call a bifemoral bivertebral artery catheter angiogram. So this patient had bilateral femoral artery punctures, 2 catheters placed in the vertebral arteries, and a simultaneous injection, which allowed us to eliminate washout from one of the vertebral arteries and get us much better pictures. Obviously, you can also see the patient's wearing some earrings as well. This allowed us to get a higher diagnostic yield. On the picture on the left, you can see that those perforating arteries are actually not coming out of the aneurysm. They're coming off of the proximal P1 segment, which is expected because perforators off of the basilar apex aneurysm dome are very unusual. And that patient went on to get some treatment, and I'll show you that treatment later. So we really take into consideration patient and aneurysm specifics. We try and come up with a treatment plan. That treatment plan will involve some form of either open surgery or endovascular procedures. The debate about clipping versus coiling kind of rages on. I don't know if we'll ever get rid of that debate. I think the reality of the situation is that there are some aneurysms that are better for clipping, there are some aneurysms that are better for coiling, and then there's aneurysms in the middle which could be good for both. More appropriately, instead of just saying coiling, we'd say endovascular therapy. We are going to talk about endovascular treatments besides coiling, which include flow diversion and now new things that we have called intrasaccular flow disruptors. So really the options are expanding. And technology moves along. I guess, typewriter-like machine in the upper left is from the 1930s. Okay, that's about when aneurysm clips were developed. The Macintosh in the middle of the screen is from the late 1980s or early 1990s. That's when the first coils were developed. And then you have a more modern computer-like system, which is the state we are in today with lots of options for aneurysms. As I mentioned, so technology is always moving forward. I'd say a lot of this technological innovation is happening in the endovascular space. One of the changes that we've seen is miniaturization, okay, not just the stents. The stents, some of them are getting smaller and more flexible and more friendly to being inside of a vessel, but the delivery systems are getting smaller. So for example, on the top you have the Neuroform Easy stent. That's what's called a vascular reconstruction device, or a VRD, that would be used to help hold coils in an aneurysm. And that's 2011. Today we have other stents, for example, called the Atlas stent, which is a more flexible stent, and it's delivered in a much smaller smaller catheter. So that makes the procedure a little easier. So we have a almost 40% reduction size in the delivery system within just a span of about 5 or 6 years. Another technological innovation, which we're seeing more of these days, is improved visualization. Okay, so these devices are made of different metal alloys. A lot of them are made of something called nitinol, which is a alloy comprised of nickel and titanium. The benefits of that is that it's very elastic. It allows stents to spring open, to hug vessel walls. The problem with nitinol is that it's not very visible with an X-ray. So some very smart people have figured out they can put a platinum core inside a nitinol wire, and that improves the visibility. And these things are called drawn-fill tubes. So we have stents or weaves that look like this. You have a weave of wires. Okay, they have a nitinol outside, they have a platinum inside, and that improves the visibility, which is shown here. So this is an intrasaccular flow disruptor before the drawn-fill tube shown on the left, so pre-DFT. And then post-DFT, you can actually see the device a lot better. So this has dramatically improved the ability to position and understand what these devices are doing once we put them in the body. Last year at this conference, I talked about, I showed previews, and this is LA. We like to think in terms of movies in Hollywood. So I showed a lot of previews, and today these previews have turned into feature presentations. So I'll be talking about the Surpass flow diverter, which is a new flow diverting stent that we have available now. I'll also be talking about the woven endobridge device or web device, which is what we just, the device we just saw with the drawn-filled tubes. Just to back up a second, we can talk about flow diversion, which is another one of these broad endovascular treatments that we now have available. Flow diversion started in the United States in 2011 when the pipeline embolization device was approved. There was then a second trial called the Premier trial, which led to indication expansion of the pipeline device to smaller aneurysms and more distal aneurysms. And then there was something called the SCENT trial. And the SCENT trial was done over the past handful of years. It led to FDA approval of the Surpass device in late 2018. And now these cases are being done on a commercial basis. If we look back at the start of flow diversion in the United States, or the PUFS trial, which led to the approval of the pipeline embolization device, this was for large and giant aneurysms from the petrous segment to the superior hypophyseal artery. So these are primarily the large and giant cavernous aneurysms, the patients that are presenting with cranial nerve deficits or embolic stroke from clot forming in the aneurysms. And this was a trial that was done with the pipeline embolization device alone, and as I said, led to its approval in 2011. The indication expansion trial for pipeline is something called the Premier trial, and this included aneurysms from the petrous segment now all the way up to the ICA termination, and also included smaller aneurysms and medium-sized aneurysms. So pipeline is now approved for pretty much all internal carotid artery aneurysms, pretty much of any size, all the way up to the ICA termination. For Surpass, they looked at something similar. They went from the petrous segment all the way up to the ICA termination, but they were looking at large and giant aneurysms. So this is a class of aneurysms that wasn't really included in the pipeline studies, because now you're talking about large and giant intradural supraclinoid ICA aneurysms. So it's kind of a different beast, so to speak, as far as the aneurysms that we're seeing. And you say, well, what's the difference between treating a cavernous aneurysm or treating a giant posterior communicating artery aneurysm? There's a huge difference as far as the flow diversion treatment and where that stent is positioned. In the treatment of a giant cavernous aneurysm, that stent is typically positioned from around the region of the ophthalmic artery back through the cavernous carotid and probably down to the petrous segment. If you're treating a giant posterior communicating artery aneurysm, that stent is anchored in the M1, so now you're covering MCA perforators with a flow diverting stent. It comes back through the supraclinoid carotid, so you're covering the PCOM as well as the anterior choroidal, and you're anchoring that stent either around the ophthalmic or coming around the intergenu back into the cavernous segment. So you're covering a whole lot more branch vessels. And with that comes its own kind of special techniques and some possibly additional risks. As far as real-world flow diversion, these flow diverters are being used everywhere. All the slides I just showed you were all about FDA indications, but we all know that once a device is approved by the FDA, we're pretty much allowed to use it as we think is clinically appropriate. And in the real world, flow diverters are being put in blood vessels in the anterior circulation pretty much as far as the vessel diameter will tolerate it. And this means M2, potentially M3. This means A2, A3, sometimes even further. In the posterior circulation, it means V4, basilar artery, P1, P2. And in the future, we will probably see those things expand even further as the delivery system for these stents and some of the stent braid density will change over time. So just to come back and talk about SURPASS, I mentioned it was one of the previews last year, and now it's an FDA-approved device. The SCENT trial included, as I mentioned, a large group of these large and giant supraclinoid ICA aneurysms. These are traditionally very difficult aneurysms to treat. These are some examples of cases from the trial shown on the right side, these large and giant aneurysms. And these are aneurysms that were not present in these other trials. The technical success of the trial was high, meaning the delivery system could be put in the body and the stent could be delivered to the target. The mean number of devices used per procedure was a little more than 1, which is a huge difference from the PUFS trial when 3 pipeline devices were being put in to treat each of these aneurysms. So we've transitioned to less stents. As far as primary effectiveness rate, so the primary effectiveness was 100% aneurysm occlusion at the 12-month time point. And the primary effectiveness during this trial was a little above 60%, which you can say was, well, maybe that number is not that great. Okay. We do know that aneurysms continue to occlude with longer time periods when a flow diverting stent is put in. So the occlusion rate at 1 year is going to be less than the occlusion rate at 2 years, which is less than, say, 5 years. These aneurysms continue to occlude over time. This trial was also dinged a little bit, I would say, in how it was designed, because a patient that, say, was occluded at 6 months but missed their 12-month follow-up angiogram was a hit against the primary effectiveness. So it doesn't really give us the full story about how many aneurysms were actually closed at the 12-month time point. And there was about a 10% major stroke or death rate associated with these aneurysms. And again, these are large and giant supraclinoid intradural ICA aneurysms that made up the bulk of this study, which is what the other studies did not demonstrate. These are a couple of case examples. You can see the large posterior communicating artery aneurysm shown in case 1 at the 12-month time point was completely occluded with vessel reconstruction. Another case, pretty much a blowout of the supraclinoid ICA shown in case 2, again treated with the device, and you get very nice vessel reconstruction from that standpoint. And this is without the adjunct use of coils, which we sometimes use for these cases as well. So transitioning over to the intrasaccular flow disruptors, such as this Webb device, this is an exciting new technology. This was developed based on what was thought to be an unmet need, which we see down in the bottom right corner. As far as bifurcation aneurysms go, we have a lot of options. There's surgical clipping, there's coiling, there's stent-assisted coiling, and the need was for an endovascular device that hopefully had the effectiveness of a clip, meaning once the clip goes on, the aneurysm's closed. They wanted that sort of treatment, but that had potentially the safety profile of a minimally invasive therapy. And that's kind of where this thing came from. These are just some of the options that were available before the Webb was introduced. Again, we see clipping, we see stent-assisted coiling. Oftentimes for a wide-necked aneurysm, if you're going to do a stent-assisted coiling, you need stents in both of the branch vessels to completely reconstruct the vessel. So the Webb device looks like this when it sits in a vessel. It basically looks like a mesh ball that's put into the aneurysm, but the aneurysm kind of needs to have the shape of a Webb device for it to really be effective. If we look at an aneurysm, say we're positioned in the blood vessel looking at the aneurysm neck, this is what the Webb device looks like in relation to coils. Coils kind of make they almost look like a ball of yarn, okay? A lot of It's not in a regular, the ball is not in a regular shape for endothelial cell growth. The Webb device is a very regular, regulated braid that provides a scaffold for endothelial growth and ultimately for scar formation, which is what completely occludes the aneurysm over time. The Webb-IT study was a study done by one of Dr. Foley's colleagues. Adam Arthur was the national PI for this study. It was in 27 centers, 150 patients, ruptured and unruptured wide neck bifurcation aneurysms, core lab adjudicated outcomes. They had approximately 85% adequate occlusion of these aneurysms without need for retreatment. And I'd say the real highlight of this study is the safety profile. They only had one patient that had a major stroke. There were no deaths at 1 year. And again, no major ipsilateral strokes past the 30-day time point. So it's probably the safest aneurysm treatment trial that's ever been performed from a rigorous core lab adjudicated standpoint. So this study led to the FDA approval of this device for use in bifurcation aneurysms at the basilar apex, at the intercommunicating artery, at the ICA termination, and at the MCA bifurcation. This is an example of a Webb case. This is a case that I was part of when I was still at Johns Hopkins. This was a Webb-IT trial case showing an ICA termination aneurysm. Webb device goes in. Within a few minutes, that aneurysm is closed. I'd say these are some more of the dramatic cases that we see where the aneurysm completely closes right from the get-go, and that's the end of the case. This was that patient that I showed you a little earlier when talking about DSA angiography. So this is that irregular, wide-necked, kind of bilobed aneurysm that we saw at the basilar apex. This was a Webb case this past week at UCLA. These are images showing the Webb device going into position. You can see as the Webb device comes out of the catheter, it changes shapes. It starts out looking kind of like a spear with a sharp tip, so you want to keep that away from the aneurysm dome. But as it transitions to its shape in B, we use the term blossoming. It kind of looks like a flower, and once it's in that position, the device is actually very soft and can be pushed up against the aneurysm dome. And then as the device fully comes out in C and in its final position in D, it takes that kind of basket shape that the Webb is designed to take. And this is the immediate post-angiogram. You can see that device sitting there at the basilar apex. You can kind of see the white outline of it, and you see the contrast stasis in the aneurysm. And this aneurysm actually was closing more rapidly than we wanted it to immediately at the end of the procedure. So this patient was maintained on an integralin drip overnight and then sent home on dual antiplatelet agents, doing fine. So just in summary, cerebral aneurysms of all sizes can potentially be dangerous. They should be evaluated by specialists. Each patient/aneurysm combination is unique, and every patient deserves at least an evaluation for a customized solution. And we're getting new tools all the time. And this year's previews, again, are next year's feature presentations, and the aneurysm treatment availabilities are constantly changing, and it's an exciting field to be in. Thank you very much.